Welcome everyone to today's webinar, Beyond the Stigma, Barriers and Breakthroughs in Black Mental Health. We're excited to have you here. Before we begin, we have a few housekeeping items to ensure a smooth experience. Please note that this presentation will run approximately 1 hour inclusive of Q&A time. Today's webinar is being recorded and will be available in the lobby tomorrow. The recording will also be available on our YouTube channel. I encourage you to use the Q&A feature at the bottom of your screen to submit your questions. We will address as many as possible during the Q&A session. A survey will be emailed out shortly after the event ends. Please take a few moments to complete it. We also have a QR code available on the last slide if you wish to partake in CPAR's research program. You may also indicate your participation on the post-event survey. Closed captioning is available to you as well. Be sure to select the CC button at the bottom of your screen to access closed captioning in real time. Thank you, and the webinar will begin shortly.
Good morning. I'm Nicole Austin Hillary, and I have the pleasure and privilege of serving as the President and CEO of the Congressional Black Caucus Foundation. It is my honor to welcome you this morning to our 2025 Policy for the People virtual health webinar, Beyond the Stigma, Barriers, and Breakthroughs in Black Mental Health. Now, I want to thank you for joining us for this vitally important conversation that's really centered on one of our most pressing issues and concerns that is often overlooked. And it is an issue that truly impacts so many of our communities, and that's the issue of mental health. At the Congressional Black Caucus Foundation, we understand that achieving racial equity and justice requires us to address the full panoply and scope of issues that impact our well-being for Black people in America. And that includes our emotional, psychological, and social health. Today's webinar is part of our Policy for the People series, which is a platform we created powered by our Center for Policy Analysis and Research. And it exists to help bridge the policy, research, and lived experience gaps that exist. Now, through this initiative, we explore critical issues facing the Black community, and we bring together experts, advocates, policymakers, all to develop real actionable solutions, because that is our hope when we bring people together for these webinars, that you will leave with actionable solutions. Now, today's conversation on Black mental health could not be more timely or more necessary. We know that our communities are facing systemic barriers to quality care, including lack of access, underfunded services, stigma, and a glaring shortage of culturally competent providers who can meet their needs. We also know that when mental health needs go unaddressed, there are many ripple effects, and they're felt in our schools, our workplaces, our homes, and most notably within our justice system. Now, today's two sessions will take us very deeply into two critical areas. The first session will spotlight the mental health deserts and communities that exist across this country, where care is not only inaccessible, but virtually non-existent for so many. Now, we will hear from leaders and experts and practitioners who are working to address the severe shortage of Black mental health professionals, and they will work to close these gaps with culturally grounded and community-based solutions. Our second session is going to focus on the intersection of social media and Black mental health, and we all know what an impact social media has on our daily lives. This will be a conversation that is especially relevant as we consider the impact of digital platforms on our sense of self, on our sense of community, and on our well-being. Now, from the spread of misinformation to the toll of racial trauma online, this conversation will help to unpack the challenges and help us to look forward to innovative and joyful ways to reclaim these digital spaces. And I told my team, I love this word, joyful ways to reclaim these spaces. It's such an important word for us to adhere to, especially at this moment. Now, we are very proud today to be joined by a dynamic group of policy experts, industry leaders, scholars, community activists, and members of our larger policy community, and especially to be joined by all of you. We know you are all committed to advocating for equity and creating pathways to healing, which we know is so vitally important. Now, as we engage in these discussions today, I encourage you to listen. not only with your mind, but please listen with your heart. The stories, the research, the strategies that are going to be shared today, these are not just data points. These are going to be tools that you can take back to your communities, that you can utilize, and that can help strengthen and empower you exactly where you sit and help us all to bring forth the promise for real change. Our goal today is to move beyond the conversation and into action, to equip you with knowledge, tools, and inspiration to advocate for systems that truly support the mental health of Black people across this nation. Moments like today remind us of why this work matters and why it is so vitally important. We are honored to have you with us, and we are grateful for your work, for your commitment, and for your time, and for being here with us. So let's get down to business. Let's move forward. Let's put action into promise, and let's make a difference and create real change. Thank you.
It is my pleasure to introduce our session moderator, Dr. Nadia Monique Johnson. Dr. Johnson is the founder and CEO of the Black Women's Mental Health Institute, a national nonprofit organization dedicated to supporting the mental and holistic well-being of Black women and girls. Through programs like the Mental Health Equity and Liberation Summit, the Sisters Speak Suicide Awareness Initiative, and the Voting Matters to Our Mental Health campaign, her organization is helping lead important conversations around mental health equity. Through its community counseling program, the organization has provided thousands of hours of free mental health services, resulting in bipartisan support for the organization to be written into the Alabama state budget, a state historically ranked 50th in mental health care access. Dr. Johnson is a professor, advocate, and trainer. She has spoken at national events including South by Southwest, the State of the Black Health Conference, and a congressional briefing by invitation of Congresswoman Robin Kelly. Her work has been featured in Essence, Teen Vogue, and the American Medical Association. Most recently, Dr. Johnson was invited to the Power, Innovation, and Leadership program at the Harvard Kennedy School. We're honored to have her with us today. Please welcome Dr. Nadia Monique Johnson.
Good morning. I am exceptionally excited to be a part of this conversation. Thank you to the Congressional Black Caucus Foundation for inviting me to be here and dive into this conversation with individuals whose work I follow and admire. I'd like to take a moment to introduce our panelists. Dr. Keisha Braithwaite is a counseling psychologist and fellow at the American Psychological Association. She is the Poussin Satcher Endowed Chair in Mental Health and Associate Director of the Satcher Health Leadership Institute with the Morehouse School of Medicine. Dr. Howard Stevenson is the Constant Clayton Professor of Urban Education and Professor of Africana Studies in the Graduate School of Education at the University of Pennsylvania. He directs the Resilience Empowerment Collaborative, a research center that unites community leaders, research, and families to promote racial literacy and health. Yolo Akili Robinson is a non-binary award-winning writer, healing justice worker, yogi, and the founder and executive director of BEAM, the Black Emotional and Mental Health Collective. BEAM is a 501c3 nonprofit national organization that builds ecosystems of care for Black and marginalized communities. BEAM funds, resources, and trains a network of Black wellness practitioners to provide wellness care to our most exploited and underrepresented communities. So thankful for each of you to be here. I believe that you're going to share some amazing jewels with those who are part of this conversation. So let's start by grounding ourselves in the landscape. The Congressional Black Caucus Foundation, along with the Equity Brain Trust, recently released a report entitled the National Mental Health Equity Framework. This report is a transformative blueprint developed by the Equity Brain Trust to address systemic inequities in mental health care and promote equitable access for all. When it comes to the US population, 1/3 of our population is living in a mental health shortage area. This disproportionately impacts Black and Brown populations who reside in low income and rural communities. Dr. Braithwaite, since you were one of the contributors to this recent framework, I'd like you to kind of share some nuggets with us. Could you give us a picture of what mental health deserts actually look like in Black communities, and how are they showing up both geographically and in terms of provider access?
Absolutely. And thank you so much for allowing me the opportunity to be here today to talk about a subject that I'm very passionate about. I want to first start by saying mental health deserts or deserts is a term that's used to describe an area where access to mental health, emotional health, behavioral health, substance abuse care or services is extremely limited and in some cases maybe non-existent. Often there are several interrelated concerns such as lack of providers, whether it be psychiatrists, psychologists, therapists, or counselors. And we know that it is already limited on a national level, but it's even more scarce and problematic for underserved, at-risk, vulnerable, and or marginalized communities. Another area that we can talk about, maybe just geographic barriers, whether it be long distances to the nearest mental health clinic or hospital in urban and rural areas or suburban areas. And so these kinds of geographic barriers can be very problematic. Thus, if an individual or family is in crisis, it can be particularly challenging to address the immediate concerns, even if they have access the national hotline on 988, which I'm sure we'll talk about later. But it's being able to connect with someone who's able to provide services. Another obstacle may be financial, high costs, lack of insurance coverage, or services not accepting certain types of insurance. And this is a major barrier that often leaves individuals, families, etc., untreated, and in some cases, their mental health problems or emotional health problems may get worse. And for those who are substance users, abusers, or may have dependency issues, it may even exacerbate and create even more problems within the family, within the community. I'm not going to belabor this, but just know that there is also an element of social and cultural stigma attached to several of the mental health deserts that we experience. That really it's problematic because people avoid seeking the help that they may need due to lack of care, obviously, or also judgment or lack of culturally competent services that are offered. And so, several of these infrastructure issues, limited telehealth options, limited access to care, etc., contributes to this growing problem that we know around mental health deserts. These deserts can exist again in rural, urban, suburban areas, and they often contribute to higher rates of untreated mental illness, substance use, and other related concerns.
So I appreciate the interconnectedness that you incorporated into that response, because I often think that when we're having discussions around mental health, mental illness, substance abuse, we talk about these things as though they're all separate, but they are all connected and they are impacted by things like access to
Yes.
telehealth, access to hospitals and just general practitioners, access to proper housing, access to food. These things are all interconnected and they impact those same populations that we were speaking about before in regards to rural and low-income practitioners. You also talked about access to practitioners. And when I say access to practitioners, I do want to mention for the purpose of this conversation, I'm also specifically talking about access to Black, culturally responsive, and culturally competent practitioners. So when we think about that, some of the glaring statistics in regards to access is that 2% psychiatrists, 4% psychologists, 11% licensed professional counselors, 13% psychiatric nurse practitioners, and 15% marriage family therapists identify as Black. What are some of the biggest barriers? And this is for everyone on our panel who is working towards addressing these kind of disparities. What are the biggest barriers to getting more Black professionals in the field of mental health? And what kind of investments and policy changes could help address this pipeline issue? And this is for anyone on the panel.
Okay, I didn't want to dominate, but I can say I'm a professor at Morehouse School of Medicine, and our vision is leading the creation and advancement of health equity to inform health justice. And so whether it be education, clinical care, research, etc., there's always a health equity lens that we're using. And so I feel like there's an importance to train the next generation of healthcare providers and create pipelines that are important for us to look at how we can support those young scholars who are interested in any number of different healthcare provider, mental health care provider roles. I will also say, for at least from my perspective, because I work with a lot of students, I can say that loan forgiveness programs are important from a policy perspective. And if there are ways that we can encourage loan forgiveness such that people are able to work in under-resourced areas, and maybe even some local or state level policy issues that can help incentivize Black scholars to be mental health professionals, that can help to some extent.
You wanna go for it? Go for it, Yolo.
I'm going to say we have to really address, and of course, it's going to be difficult to do so in this environment, racism, homophobia, and transphobia in social work programs and in psychology programs across the country. One of the things I often note is that in my social work student experience, there was a course called Diversity in Social Work, which really clearly taught me that, oh, this program is designed for white people to understand Black and brown people. But there was no program that's taught me about how to be a Black person navigating social work in the context of whiteness, or how to deal with white clients, or institutions and frameworks that were not designed with my culture and community in mind, right? And so in addition to the exorbitant cost, we have to recognize that many of these programs have been designed with this not in mind, been designed from this academic hazing perspective, which is brutal on the psychology and mental health of Black and brown folks, right? And so we have to change the ways in which these academic systems are designed. We have to actually recognize that many of these psychology and social work programs talk about teaching mental health, but they actually create poor mental health for their students and the professors. And so that's actually counterintuitive to the culture they said they espouse to create. And so I think those are pieces we have to really get clear and honest about, transforming the embodiment of these systems, and not just about the theory behind it.
Yeah, and I would just add to what Mr. Robinson is saying, that discrimination makes a difference. So in a sense, even if there are resources, folks don't trust them. So they're less likely to use them in that process. I think the issue of competence really is exceptionally important, because it takes time to understand the experiences of Black and brown folks in these situations. And so if schools aren't doing it, academic centers are not doing it, and some are not. We also have to deal with the problem that even if we degreed more people, twice as many as we're doing now, we're still not going to meet the need of Black folks' mental health issues over the next decade. And part of that brings us to, how are we going to use resources where people go to natural healers? Some of the research on natural healers brings up notions of how we have to think outside the box of traditional systems. So there is this tension, I think, between what constitutes competence, what constitutes who can teach folks. And in the climate that we're in now, where folks are challenging cultural responsivity, we're dealing with a couple of whammies at the same time to even get close to being adequate, even in over-resourced communities.
Mm-hmm.
Absolutely. So your responses were so incredibly powerful. I can also speak to the work of the Black Women's Mental Health Institute. We have a clinicians in training program where we support master level students to graduation and to full licensure. And some of those same barriers in regards to costs and the expectation that after you receive your master's degree, you have to complete 3,000 hours of additional training, and that training is done for free, and individuals are trying to juggle that while working other full-time jobs and taking care of families. So it's essentially free labor before they can become actually licensed to provide care to the community. And Yolo, what you were saying earlier, I'm going to just tell you right now, all I heard was Audre Lorde in my head, right? The master's tools will never dismantle the master's house. And we have to have very honest and direct conversations about the Eurocentric nature that's built into the foundations of how we understand mental health and what the expectations of our practitioners should be. So as you were speaking, I was just saying yes, 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 through my spirit. So I really do want to take this next question to you. Your work at Beam emphasizes community-centered mental health. And in the face of the workforce shortage, and you being a yogi, and individuals and other healers like doulas and Reikis and drumming circles and herbal therapies not being taken in consideration and giving the validity that they should be, how can we rethink who delivers care and how that care is delivered, especially outside of the traditional kind of Eurocentric clinical settings that we just talked about?
Absolutely. Thank you for that question and introduction. One piece I want to be very clear about that I think we need to reframe is to understand that in Black communities, traditional mental health care is community-centered mental health care,
Yes.
right?
Yes.
We often use this language of traditional, but Western mental health and psychology is relatively new to human history compared to the practices and rituals and regulation strategies that African and Black communities across the world have. Right. And so long before we were allowed to become therapists or psychologists in our communities, we had those practices. We would not be able to be present here today if our communities did not have some type of practice, whether it's, as you said, healing circles, whether it's herbalism, whether it was prayer circles. All these are strategies that can be built up and further resourced to support our folks, right? And so at Beam, one of the things that we do is we fund and resource an international grassroots network of practitioners and therapists and wellness folks, because we recognize that in every hood, in every underserved community, even if there is not a therapist, there is someone people trust to go to for crisis support, for wellness support. Sometimes it is a barber. Sometimes it is the big mama. Sometimes it is a teacher. It is a coach. So our focus has been for the last 2.5 years, we've invested more than $500,000 into that network of 62 organizations across the United States to support the most underserved folks, giving them more skills and tools and resources to build upon what they already know, right? So as opposed to just like only focusing on the professional class, we need to focus also on this community grassroots wellness network of folks who will show up for our people and are trusted sometimes more than traditional therapists and mental health practitioners, because we have to recognize that for most Black people in the United States, the prison industrial complex and the mental health system are not separate entities. They don't experience them separately. They don't have the privilege of having a really wonderful Dr. Johnson who has a gorgeous office they can go and talk to and affirm them. They're experiencing an overworked social worker who has a caseload and they can't see them for 6 to 7 months to get the care. And when they get the care is not supportive. It's not helpful, right? And so for us, I believe that it's imperative for, as a part of a Black mental health strategy, in this moment where we see a public divestment from public health infrastructure, we have to turn to our community grassroots wellness initiatives. We have to look at all the organizations and the folks on the ground in the churches and in the barbershops who are trusted to do the work. We fund organizations like, for example, Darkness Rising in North Carolina, where they actually have a program where they support folks who are formerly incarcerated with getting 10 free therapy sessions, but not just like saying, I'm gonna give you any therapist, partnering with them to figure out what their care needs are in a way that is collective, right? We support organizations like the Take Center in Birmingham, Alabama, which supports Black, queer, and trans young people in the rural part of the country where often Black, queer, and trans lives are not valued, right? And so these organizations may not have the glossy, big federal support. They may not they may not have the big glossy websites, but they're doing the work that the hood trusts. They're doing the work that the people trust. And that's what we need to focus and look at and resource, because they're going to be the people that are going to hold us down in the midst of these political crises.
Yes, 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 yes. If you're going to do the community work, you need to go into the community, engage the community, become a part of the community, and understand how they frame wellness. It reminds me of some research that I did at a predominantly white institution, and I was looking at mental health. And in talking with their Black population, they were not going to the counseling center because they did not have representation, and they felt like the clinicians there weren't properly trained to address their needs. But guess who they went to talk to? There was a Black female administrative assistant in one of the student affairs offices, and they would go into her office and cry. She would make them some cookies. She would cook for them on the weekends. That is healing, but they would never recognize her for that. But she was doing the work that their established counseling center was not able to do, and the Black students went to her versus them. So everything that you're saying, yes, community work.
And Dr. Johnson, I love that example. It's a beautiful illustration of the work that we know so many of our folks have been holding. I also want to hold that we also have to build up the skills of our folks in those communities. Our folks have some dynamic skills. I don't want to romanticize it. Sometimes the reality is the Big Mama might say some things that might not be helpful. Sometimes the reality, the barber who we trust, Steve, he might say some things. That's why we designed our own program, Black Mental Health and Healing Justice, a peer support program, to really build upon what we saw as the limitations of mental health first aid, right? Our Black Mental Health and Healing Justice program starts off by acknowledging all the harm that has happened in the mental health system to our folks. It doesn't come out of anywhere that our folks are scared of mental health, right? If you think about Atonia Hilton's book called Madness, which looks at the history of psychiatry and mental health in Black communities, you see that our communities are understandably afraid because the mental health system has exploited our folks. Yes. And so we start our program with acknowledging that harm, but then saying, guess what? There also are some Dr. Johnsons and some Dr. Stevensons out there in that system who you can ally and find who will collaborate with you to get care in that system. Let's give you skills, tools, and training to find those folks and collaborate with them in the context of the system, right? And so I think it's important for us to focus on building more training programs that focus on the entire village, not just the professional class, because everybody's skills need to be built up. Mama, Daddy, Uncle Pookie, everybody needs skills built up in a collective environment.
Yes, absolutely. Absolutely. So staying with this idea and these innovative solutions and this really moving conversation, Dr. Stevenson, you've done a lot of work in racial socialization and healing in community spaces. How do these kinds of culturally responsive approaches help fill the gap in places that lack formal mental health infrastructure?
Oh, it means a lot. And it also is not just the interventions, it's also the measurement. Even the measurement does not reflect how we can capture whether culturally responsive work, like Yolo is describing, is actually working. So in the same way that we want to build skills, we want to measure how effective is it? And over time, those things are still important. We did a study with Dr. Loretta Jamat and John Jamat, and I pulled together 800 men over the course of 5 years and trained about 50 barbershops with about 3 barbers per shop. Oh, and over the course of that time, we were able to teach Black barbers skills around how to teach racial literacy and violence prevention, as well as safe sex protection while they're cutting their hair. And the barbers, as you know, are culturally stylistic. I mean, one point about where you want to go in terms of helping Black and brown folks. These were men, but in the sense of where do they go to tell their stories? And in barbershops, Black men will tell a story that's very private with other men in the space, and some will stay in a barbershop all day and never get a haircut. There's something comfortable about that space, that science, that those of us that are interested in culturally responsive. Why are men talking? Why are men talking about their personal issues? And why do they trust this person with this who's cutting their hair to do it? There's a lot of things that go on. There's touch that goes on in these spaces. There's affirmation. There's confrontation. There's challenge. And what we found is when we asked them, they said barbershop is the only place I can go. About 90% of the men said the barbershop is the only place I can go. But 90% of the time, I not only go leaving feeling good, I leave looking good. And I don't feel that so much in my partnerships, or even sometimes in my church relationship. So where can we go? And so we can do more science around how do we teach the skills of barbers to not only become perhaps therapists? How do we help some of our community colleges support these young men and women as they are not only cutting hair, but getting a degree in counseling so they can supplement their work? We know that many of them also have health issues by standing all day, in their shoulders and their necks and their wrists. So we could bring insurance policy around these community centers so they're long lasting. You can make more money. And the last thing I'll say, barbershops are one of the few places that men coming out of prison can go to and get a job that's stable. So barbershops will be there for 30, 40 years in what we found. And not even some churches stay that long. So part of the idea of not only beauty shops, barbershops, we can do this and we can teach the skills to everybody, not just, as Yola was saying, the professionals.
Absolutely. I can honestly say that I attended a barbershop event for Black men. It was the most Black men I've ever seen in one space at any moment in any state that I've ever traveled to discussing mental health. It was a massive event, and I just thought, wow, this is spectacular. And they really framed it around barbershop conversations and mental health. The transparency that was in that room.
Yes.
I've ever seen a group of Black men like that. So I appreciate the work that you're doing. I do want to bring to this conversation policy. In his book, The Political Determinants of Health, Daniel Dawes really kind of dives into how political decisions, policies, and structures fundamentally shape health outcomes in the United States. So I want each of us on the panel to kind of consider this. What are some of the promising federal or state level policies that could both expand mental health workforce and incentivize professionals to practice in underserved populations? Anyone? And I'll give you a quick example. Our organization is founded and headquartered in Alabama. We do a lot of work nationally, but we pilot a lot of things in Alabama. And some of the largest disparities in our state exist within the Black Belt. And it's very difficult to incentivize young practitioners to go there and stay there and do work when the community doesn't provide some of the amenities that they may be looking for, because it is very rural and it is very low income. So I want to throw that kind of in there as well. What are some of the things that could incentivize individuals to go to their communities? And what are some of the federal and state level policies that will expand mental health and the workforce that would also incentivize them to go into those communities?
Well, I will say this. While I have deep appreciation for folks who work closely with state and federal institutions, I am definitely a part of the maroon legacy of Black folks in this country, if you know what I mean, creating grassroots initiatives on the ground. But I also want to uplift that in the state of California, where I'm currently, there are some legislation and policy I think is useful for us to think about. For example, with Medi-Cal, they have expanded it to be able to support reimbursing and supporting traditional healers and natural helpers in our communities, right? We also see work as well in California around supporting peer recovery specialists, people who are quote unquote not traditionally, not counseled, credentialed as therapists. But I also want to hold that oftentimes those credentials and those reimbursement and payments are often subpar, and often they're underpaid. They're often at poverty level wages. So that is a problem. But I think that, like, if we begin to think about, for folks who do that work around federal and state work, really making sure that those people are compensated and paid well, that is a great strategy to begin to explore, to expand.
Yeah, I would add to that. I think we have to figure out ways to monetize taking care of ourselves. So in the way that I was describing, how do you bring barbers, for example, in a space where they can actually make more money by getting a degree for doing the work they do in these places? You need a policy that thinks about their health in doing that work and to stay in it for long periods of time. You need to think about how do folks who know about monetizing these resources, because barbershops can do a lot more than just cut hair. And you could think about what are those things. We have a project called PLAY, standing for Preventing Long-Term Anger and Aggression in Youth, which uses physical activity in basketball. We have underutilized coaches. We've underutilized sports coaches as folks who also could learn these skills around mindfulness and healing. But I still think you need projects that are willing to think about healing integrated into a business proposition, so that as you're healing folks And they could be in the context of a local 1 to 2 block radius. There's a church, there's a school, there's a community of folks that could say, in this particular locale, what are the business opportunities and where are the resources can we multiply in a particular way?
I agree 100% with what has already been stated. I do want to emphasize that it's important to realize that there's no health without mental health, which was a term coined by Dr. David Satcher during his tenure as a U.S. Surgeon General. And I just, so a primary care center may be at least a place where people can get some level of care for physical health, but also connect with their primary care doctor if they even have one, and talk about some of the issues that they may have, and then they can connect that person or family members with a mental health provider. It's really an integrated care model. And some federally qualified healthcare centers, actually all federally qualified healthcare centers, the FQHCs, are required to have mental behavioral health as a part of the care offering that they provide directly, or at least connecting someone to care. And so I guess really what I'm getting at is that I don't want individuals to feel like they need to be overwhelmed with, I need to start with a mental health provider, counselor, but they can start at their primary care physician or community-based healthcare center if that's something that they would have access to, and then allow them to help support them in facilitating identifying someone who can offer the mental health services.
I also want to
Absolutely. Yes, please. No.
I also want to lift up a strategy that Beam has been employing along with American Black Psychological Association. We've been talking about the need for what we call healing circles, right? And so at Beam, we call them we have a program called Heart Space. And what Heart Space is, it is a monthly space that we hold in person in Atlanta and Los Angeles, as well as virtually. We have a revolving cadre of different practitioners come in and teach on a community level. Skills, strategies, tools, education, right? It's low cost because once again, it's collective. There's many people in there. You can come in for free or for very low cost. And it provides an opportunity for people to get access to therapists and psychiatrists in a community setting in a way that is affordable, right? But also they're learning with other people in the community. So now my mama's with me, my cousin's with me. We're taking this back and we're integrating this in the community collectively. I really want to encourage us to think about not just in one-on-one models. One-on-one care will always be needed. We know some of us need to sit on a one-on-one situation sometimes, always. But we also need to build out more collectivist strategies where
Yes.
multi-generational folks are coming together to say, we're learning about trauma, or we're learning about internal family systems therapy, or we're learning about, how gender and masculinity impact our mental health together. And now we're having those conversations, taking those skills and tools back to our community. So I want to lift up that we need to think about collective strategies more and more and more, like Heart Space, like what APSI is doing as well.
I love that, YOLO.
Absolutely, absolutely. So, and Yolo, I'd actually also like to thank you as a Jamaican American for bringing in our maroon ancestry into the conversation and creating that spirit. I appreciate you. We are about that strategic resistance. I do see quite a few questions coming in from the audience, and I want to make sure we make space for some of them. One of them, Yola, was directly towards you. Does your organization have, do you use Black mental health in your Healing Justice program as a substitute for mental health first aid or in partnership with it? Do you actually encourage people to do both, or are you only using the Healing Justice?
Right. So we encourage people to engage in whatever tools and practices work best for them. And I'm going to say that Beam created Black Mental Health and Healing Justice because myself and my colleagues, we saw that mental health first aid, going to that training, we recognized we tried to do that in the hood. And people were like, well, first of all, where are we even addressing the history of mental health in Black communities? It's not even in the training. right? So that wasn't present. And then when you even talking about the nuances of gender and sexuality and race and why our folks were afraid of navigating mental health. And then I feel like mental health first aid is too focused on diagnostic criteria when it's not for mental health professionals. We focus on symptoms. We're like, you don't need to be out here diagnosing people and using this categorization. You need to be focused on symptoms, how to support folks, and how to get them in a broader care and recognize when they need broader care when necessary, right? So giving people baseline community-centered skills around care, listening, affirming, partnering, education, and not so heavy on diagnostic criteria, which we have found historically was not helpful. And so for us, we created a Black program, right? Where there's, in the context of that program, there is also embodiment practices. We build upon what Black people already do in our communities, because we already do a lot of things in our churches and our barbershops and our communities that actually cultivate wellness. So we build upon them to make them more dynamic. And so that's what we do. But once again, we encourage people, because I've been to some mental health first aid trainings, and I love us so much. Because I'd be like, now, girl, you know that was amazing, but you don't change that curriculum so much. It ain't even the same thing. You had to do so much to make it fly that it ain't even the same thing anymore. But we just attaching to the name of it because we know it has nationwide recognition. But let's not forget the mental health first aid was made for prisons, prison guards. It was not made for community. It was not made for with thinking about cultural competency. So I think that's important. One piece I want to drop into through our program, and I want people to know this, we are one of the few Black-led and Black-founded organizations that principally focuses on supporting grant making for other Black organizations, right? Mental health organizations. And so we have our Black Wellness Innovation Fund, where we have given out grants and resources to Black organizations. Our Southern Healing Support Fund does the exact same thing. People in rural communities who are doing that healing work. That is the work that we resource to make sure that folks are getting care, because we know so many Black people, and I would say a lot of Black women, a lot of Black men are doing that work without any compensation, and are really suffering and struggling to take care of communities that have been left behind by federal and state policy.
Absolutely. Absolutely. Here is another question from the audience. This one seems a little bit more personal. Maybe someone is looking for some strategies for themselves, but how can we best handle mental health issues for African Americans that arise from workplace discrimination, harassment, and social media bullying?
So if I could make a pitch for why the research on racial socialization over the last 30 years has been useful, is that we've learned that families who talk to their children, or educators, or leaders who talk and prepare their children for what's going to happen, those children tend to do better at standing up for themselves, at realizing that hate that's coming at me is not about me, it's about you, and they can separate those things. And that research over time has led to us understanding that even if I can stand up for myself and I can find my own voice, it affects my sleep quality. So, and that sleep quality issue can go from teenage years into my adulthood. Now, racial literacy is like taking racial socialization and upping the game in terms of practicing. Instead of, sporadic, maybe we'll give the talk to our children. Racial literacy is saying, here's how we're going to intensify giving this talk. And we're going to practice not only what could happen to you, and could be very early in your age, because we know even in preschool, we get discrimination. We have stories from young people in third grade who remember stuff that happened painfully to them in first grade. Students will tell us that. Is this capacity to also practice over and over again. So we'll do practice healthy and unhealthy racial comeback lines, because you need a way to use your body and your attitude and your soul when somebody steps in your space. And being proud of who you are is nice, but it's not going to help you when somebody's in your face. And you're going to think about that before, during, and after. So practice. And we think about racial literacy as this capacity to read, recast, and resolve. Read and notice when stuff is not right, the elephant in the room, even when other people don't see it. Recasting is I'm scared on a scale of 1 to 10, 8, 9, and 10. How do I bring that down to a 5, 6, or 7? And the resolve is making a decision where I walk away not swallowing, underreacting, pretending like it didn't bother me when it really did, for 2 days, for 2 years, for 20 years. Or overreacting and cursing everybody out. The capacity to be able to use your voice to stand up for yourself is important for young people, for older folks. It doesn't matter how to find your voice. So racial literacy. You got to heal if you're going to fight. You can't just fight without a healing strategy.
Absolutely.
And
Absolutely.
in alignment, no, I was just going to say, in alignment with what Dr. Stevenson mentioned, I want to emphasize how important prevention is. We want to identify ways that we can take care of ourselves and manage our stress or stressors such that it doesn't get to a point where it's very, very difficult to manage ourselves overall, and move forward in life in a productive way. And so we know that there are systematic barriers, issues, psychosocial, sociocultural, environmental, economic issues that exist, that, and all of these things, the thing that happens, as we know, is not one thing that happens on its own. It's a combination that come from different directions. And so to whatever degree we can prevent ourselves from going down a rabbit hole or not being able to function appropriately for ourselves, we need to really look into strategies and approaches that are going to help us to move forward in a positive way.
Absolutely. Absolutely. So I do want to kind of make a little space for talking about teletherapy and technology. There is this move now, especially after the pandemic. We've noticed it with our work, where most of the individuals who are looking for counseling for your sliding scale are asking for it virtually. But we also know that there are limitations in regards to areas that do not have access to proper Wi-Fi or stable Wi-Fi, or even have access to the devices. I think sometimes we take for granted that everyone has a smartphone, which is not the case, or everyone has an iPad and whatever technology. That is not the case. So how well is teletherapy truly serving Black communities facing geographic barriers or technology barriers? And what are some of those solutions that we could bring to the table to address this disparity?
Well, I think it's important to acknowledge so often who telehealth is not helping, you know. I just want to acknowledge that, like, I know we have a lot of virtual programs that we offer, and sometimes it's difficult for us to get some of our elder members of our community onto those networks, into those Zoom spaces, right? We got to pull up in the community where they're at, right? And so I think we need to acknowledge that that is a barrier, but we also know that a lot of younger generations, they are on the TikTok, they are on the Zoom and all those mediums constantly, and trying to figure out ways to reach them through those mediums. So I think that I just want to hold the nuances of, like, who are you reaching? As you said, Dr. Johnson, like, you know, a lot of us, we make the assumption that everybody has access to internet, access to a good signal of internet, right? And also access to these platforms in a way that can really be helpful. And that also that it translates for them, right? It doesn't always translate for many people engaging in that medium of telehealth, you know, in terms of feeling comfortable to disclose the full range of what they're experiencing. Like, sometimes people need the embodied in-person experience.
Absolutely. Anyone else? Okay, so I feel like we've touched on this a little bit already, but I do want to speak directly to trust. This is a topic that's come up a bit in some of the questions that have been posted. How can we build trust with the mental health systems that we have, but that we also acknowledge have historically overlooked us and even harmed us? And what role do Black providers and culturally affirming models play in rebuilding that trust? I do want to incorporate another question that came into the chat into this question. When it comes to some of these anti-DEI efforts, and thinking about how our future mental health workforce is being trained in universities, and how it was already limited in their ability to incorporate these concepts into their required curriculum. I'm going to say required, because oftentimes diversity and, you know, Black mental health and all those things, they were electives. So how now that that's even further removed, how can we make sure that we build trust into the systems, but also make sure that we incorporate that training for our future mental health workforce, because they need to understand how mental health manifests across different populations. So I kind of want to put the question that way.
I would throw out a couple of things. One is the same way that we're trying to think about what's natural healing look like. Where else can we go than traditional systems? You have to, it's almost like we still have to start from scratch about what is our history? What is Black history? Why is it so important to understand? Why was somebody trying to erase it as a first step in trying to do this stuff we now call anti-DEI? And part of that is, when we know the history of what has happened to us, this will not seem strange, all of these events. And that's important for knowledge sake. So to the point where trust comes is this notion of the hardest thing I find still, after 35 years of finding research that suggests that discrimination causes harm in a particular way for very young, even for young children, is that most of us don't really know that, right? So someone could take away the DEI thinking that it has, that discrimination is not a thing, right? But we know that not only does it affect, if it affects sleep quality, if it affects relationships, it affects depression, anxiety, and suicide rates. We've got to do a lot more teaching, even in in our natural healing spaces, of the cost when somebody steps to you and dehumanizes you. It's not a small thing, and it can last. And so whatever we build, we gotta make clear about that. And our history is the most beautiful thing we have to keep us alive, because the blueprint and the solutions are stuck in those narratives. And I just argue softly, folks can do this. And I'm not even talking about folks who are so stone cold racist. I'm talking about well-meaning, nice people still don't get that discrimination affects outcomes differently for Black and brown folks than anybody else. So that would be my 2 cents with that.
Would anyone else like to chime in?
I was going to say my 2 cents is, to build trust, we have to be honest. Okay. One of the things that we do in our programs and that I constantly say, I say, look, just like every barber that has a license don't mean they know how to cut your hair and roll your braids. Every Black person who got a credentialing doesn't mean they are a good therapist for you, or that they are an integrity-based therapist, or that they are down for our people. And so we need to get honest and kind of diffuse this myth that like everybody who got a license is actually doing amazing dynamic work. We know from the complaints from the American Psychological Association annually alone, that is not the case. And so we need to get people to get honest, like, just like I had a person a long time ago come to me say, well, I went to one therapist once and I didn't like them, so therapy doesn't work at all for me. I'm like, well, hold on. If you go to the barber and they cut your hair wrong one time, do you stop getting your hair cut forever? He was like, well, no, I gotta go find another barber. Exactly. So you gotta go find someone else to get your needs met, right? So we gotta get honest about the system. Take away this kind of evangelical, godlike stature that people are giving to therapists. It's dangerous. It's not healthy for therapists and wellness practitioners. It is not helpful for our community. And get real about the system and say, let's find the folks you trust. Let's find the folks the community trusts. And sometimes those people are the credentialed people, and sometimes they are not, right? And we need to talk about that piece and get honest about the real challenges that come along with getting care and supporting our people through that process.
Absolutely. Absolutely. Now let's talk about an opportunity that we have. We've talked quite a bit about the workforce shortage, but let's talk about the opportunity that we have to build the pipeline with young people. Our organization has a clinician in training programs that I already mentioned, works with graduate students and recent graduates, but this fall we're launching a mental health career navigation fellowship where we'll specifically work with high school students to introduce them to the field of mental health, because they honestly don't know the difference between a psychiatrist, a psychologist, an LPC, and an LMFT. So they can't even consider it as a potential career if they don't know what those things are. But we also want to introduce them from the start to these different frameworks for understanding mental health, and not just the Western ideas that are built into our mental health care system. So I do want to kind of share this question with the panelists. What can be done to encourage more Black students to pursue careers in mental health early on?
I would just say they got to see us everywhere. I mean, we have to be everywhere, and we need to talk about it. You know, yeah, I mean, I think The reason we are using physical activity in sports as a way to go is because we can have access to parents, to students, to even grandparents, to coaches in ways that are still community. Sometimes people spend all of their lives in a sort of physical active space. The brain science around physical activity, though, is amazing, that that we can use movement as a way to keep us focused. And we are underutilizing that. Schools that are actually adding more time to study are missing the boat around the benefits of physical activity. So why there are cultural ways to address this. So I would just say, yeah, that's one area I think we could do better.
And,
But I think we have to be, as psychologists, we have to be everywhere. We have to be in the hood. We have to be here. We have to be in places that people don't even speak about. And I grew up in a community where if I go home, people think it's nice that I have a degree, but what they really care about is, do I remember them? Have I forgotten who they are? And that's a particular lens. That's a particular set of values about who are we committed to? Who have we forgotten that look like us? That's important, I think.
And then in alignment with that, I think it's important for us to have mentors or a formal mentoring program in some of the schools or different spaces, because mentoring and a mentoring team can really support those who are interested in going into whether it be academic space or in communities, etc. But mentoring is everything, and sponsorship too. Having someone who takes them under their wing, so to speak, and kind of helps guide them and direct them into different paths that they can consider.
Absolutely. So we are going to begin our close, but there's something I really want to acknowledge, and it's the community that we built without even thinking about it. Our webinar chat, you have built community in that chat. And when I think about the conversation and the questions and just the support that I'm seeing in this chat, I want us to really understand that we have the answers and we have the solutions. We just need to work collaboratively to get those things done. So I do want to say this very directly, that I'm going to be looking into this chat after this discussion. I'm going to be pulling your comments. I'm going to be pulling your email. Many of you have popped in your website for organizations that you work with or companies that you work through. And you've also mentioned some community programs that you're doing across the country. If you've not already done so, drop your email address, drop your website, let us know what you're doing. The solutions are there and we need to know each other and work together. So I just appreciate it. Actually really fills my heart with a lot of joy, and I'm very encouraged about what we can do together just based on what you all have already done in this chat. So please keep that going, and I will be following up on every single one of these comments. I promise you that. So as we close, I'd really like to leave everyone who's been a part of this discussion today with actionable steps for how we can strategically reimagine the future of Black mental health care. So for each of our panelists, if each of you could either share some piece of advice for everyone who has been here in attendance on how we can access and increase access to mental health care, how we can play a role in being a part of the transformative care and change that's needed in Black mental health care, I'd like to just ask you to give an actionable step and a piece of advice for how we can all be a part of continuing this work.
I can start. One thing is we need to read and be more aware of resources that are available. At the opening of this webinar, it was mentioned that I am a part of the mental health equity framework document, or developing the mental health equity framework document, and CBC Foundation has access to that on their website. And so I just encourage you to get it and become as knowledgeable as possible. And so I think we need to just read more. I guess I'm speaking to myself. I need to read more too, just to be more knowledgeable about implement it to help support building this network of Black scholars?
I would just throw in, thank you, Dr. Braithwaite. I would throw in, we teach everybody a mindfulness approach called calculate, locate, communicate, breathe, and exhale, CLCBE. We teach it to third graders who can learn it, and we teach it to folks in their 80s. And basically, it's based on this notion of how you take care of yourself in the moment. There's an African proverb, West African proverb, the lion's story will never be known as long as the hunter is the one to tell it. And so for you to get some support for you, you got to learn how to tell your narrative, your story, your way, and your how. And calculate simply stands, what feelings am I having right now? And how do they rate on a scale of 1 to 10? 10 being intense, 1 being not at all. Locate is where in my body do I feel it? Because we leave the body out too many times around stress and health and healing. Communicate has 2 parts. What do I say to myself when I'm going through stuff? And what do I see in my head? What shows up in my mind? And finally, breathe and exhaling, CLCBE. You can take that with you.
Brilliant. Just expressing immense gratitude to be in this space with such healing and wellness superstars, Dr. Bradford, Dr. Stevenson, and Dr. Johnson. Appreciation. I want to tell everyone that everyone in the village has a role in healing and wellness of the community. Everyone. You don't have to be a counselor and a therapist, but you can get some skills and some tools to be able to supplement and support and resource your community from the boundary that feels good for you, right? I always tell people that everyone has a limitation to their practice. Sometimes people just need somebody to listen and hear them and be present with them, and that is the intervention. When you learn how to do that, you can be supportive in the community. It doesn't mean that if you're a yoga teacher that you need to have acupuncture needles. If you don't know how to use those acupuncture needles, don't do that. Stay in your lane and do your boundary, right? Understand and be able to understand that this is beyond my scope of practice. This is beyond what I know how to hold. Get some skills and tools from some Black-led institutions and individuals who are doing the work in our community. Make sure it's inclusive. Make sure it holds the nuances of not just Black and trans queer people, but Caribbean folks, the nuances of Black communities in the United States, because we are all very different and multiplicitous within our communities, right? So I would say start there and connect with us, connect with all the organizations that have been lifted up in the chat, get some skills and tools, and find the local grassroots folks who are doing the work in your community. In every hood, there is a barber, there is a small organization. They may not be that big, but they're doing work, supporting people who are survivors of gun violence or whatever it is. Find them, link up with them, help them get more tools and skills and resources. And that is how we build up our international network.
Absolutely. So I thank everyone for being a part of this discussion. Thank you to our panelists. I encourage everyone who is in the audience to follow the work of our panelists. Please follow the Satcher Health Leadership Institute with the Morehouse School of Medicine, the Resilience Empowerment Collaborative with the University of Pennsylvania, BEAM, the Black Emotional and Mental Health Collective, and of course, the Black Women's Mental Health Institute. Dive into the mental health equity framework that the Congressional Black Caucus Foundation and the Equity Brain Trust have put together. That resource has been placed in the chat multiple times, but you can also find it on the CBCF website. And I would like to just finally close for thanking the Congressional Black Caucus Foundation for making space for this important conversation and really highlighting mental health in the Black community. Thank you all for joining us.
Good afternoon, everybody. My name is Dr. Jonathan Cox, and I'm the Vice President for the Center for Policy Analysis and Research at the Congressional Black Caucus Foundation. Now, in closing out our first session of the day, I wanted to offer a huge thank you to each of our speakers. Now, they all provided thoughtful, timely commentary on the important topic of mental health deserts and the mental health workforce shortage. And I know that I personally benefited significantly from their insights. And I imagine that each of you all that are in attendance have as well. And speaking of attendees, I also want to offer my sincere gratitude to each of you for joining us today. Now, it is our goal and privilege at the Congressional Black Caucus Foundation to provide relevant, timely information on issues that are important to Black communities, and to use this work to help push positive policy changes that better the lives of Black people in America and everybody else as a result. I hope that you all have found today's first panel to be engaging and informative. Now, before I let you all go, I wanted to share just a few quick items with you. First, please be sure to check out all of these resources that have been mentioned that we made available in the event chat throughout the session. Now, the Center for Policy Analysis and Research team cultivated these resources to be helpful, informative tools related to Black mental health, as well as to provide connection to the work of the speakers. You can also sign up to be a participant in future research with CPAR by using the QR code provided in our rotating slides. Now, second, and along the same lines, please, again, make sure that you're checking out CPAR's research and policy work by visiting the CBCF website, www.cbcfinc.org. Now, of note is our recent executive order tracker, and that provides updates and information on many of the executive orders and other presidential actions and their impacts on Black communities, as well as what members of Congress, particularly the CBC, have been saying and doing in response. Third, I'd like for all of you to save the date for our upcoming Policy for the People Health Equity Summit. This will be an in-person event taking place on May 20th at the Capitol Turnaround in Washington, D.C. Now, this summit focuses on access and affordability in chronic disease treatment and management for Black communities. And so you can go to our website now to reserve your spot. It's free to attend, so we hope to see you there. Now, finally, if you're able, please join us today at 1 p.m. for our second session on Black mental health in the social media and digital era. We have another great lineup of experts to provide insights into the topic, and I'm looking forward to another engaging discussion. Once again, thank you all for attending and have a great rest of your day.